Good evening, everyone. I welcome you for the ACP India case files. And today is a very, very special day because just yesterday, the ACP India, I think we are live. Good evening, everyone. I welcome you all for the ACP India case files. And today we have a very, uh, very good program where we are going to talk about a very interesting case of ascites. And Dr. Anuj Maheshwari sir will guide us that how to advance to the fellowship of the ACP India chapter. But before we start the program, I would like to congratulate all the ACP members and Dr. Anuj Maheshwari sir, especially the governor of ACP India chapter, because just yesterday it has been confirmed that ACP India chapter has received the gold award for the best chapter category all across the world. So many congratulations, Anuj sir. And it is really a proud moment for all the ACP India chapter members.
Actually, it is a three-tier system of the award in which awards are given to the various chapters depending upon their performance. That is gold, silver, and bronze. Last year, our chapter has stood for the bronze, but this year we had jumped directly to the gold because of our collective activities, collective efforts, what all ACP members has done across the year. Our popular membership and our popular membership drive, and we did a lot of activities across the year. Throughout the year, we completely remained with the news and noise. So that news and noise has definitely made it that we could jump directly from bronze to gold. With gold, a good number of the other chapters are also with us who are sharing this gold status of the Chapter Excellence Award. But this is really good for the India chapter because India chapter has first reached to that level, for the first time reached to that level where it has not been reached before. So this is really a good thing for all of us. So I must congratulate to all members of the ACP India chapter for this evening on this accomplishment.
But sir, I would like to tell all the members here that Dr. Anuj Maheshwari is a 24/7 and days he is working around the clock for the ACP. I have seen him very closely. And now the ACP India chapter has a lot of activities, including the scientific activities, academic activities, research, social, student activities, activities which are dedicated to the women, activities dedicated to the early career physicians, activities that dedicated to the medical students and resident doctors also. So I don't think there is any other there is any area which is not being covered by the ACP, and the membership engagement is again very high because the ACP, the primary objective of the ACP activities is to give the members a sense of engagement and the sense of benefit which they derive from the membership. So just sir, for the customary, I would ask the RX team to display the introductory slide of Dr. Anuj Maheshwari, because many of our people will be joining for the first time also. So it is the honor for me to introduce Dr. Anuj Maheshwari. Dr. Anuj Maheshwari is the governor of American College of Physicians India chapter. He is professor in medicine at Hind Institute of Medical Sciences, Lucknow. He is a great academician and a great teacher. He is fellow of all the renowned societies of India as well as all across the world. And he is also the vice president of RSSDI. And he has been involved in a lot of research activities, many publications, and a lot of awards to his credit. And he was also awarded the Wellbeing Champion by the American College of Physicians in 2018, and Marvelous Personality of the Year 2017 by the Governor of UP. So, sir, it is indeed an honor for us to have you here, though you are also the host of this program, the Early Career Physicians program. And today we are going to talk about how a member of ACP can advance to the fellowship of the American College of Physicians. So, sir, my first question to you is that what is FACP, and what does it means, and what is its importance to a member?
Yes, definitely, very good question. And actually, we should start with this question: what is FACP? Many a times we start getting the fellowship of various organizations, but we don't ever think about Why did we take it, and what is this? What we have already got it. It is simply an honorific suffix after our name, or it has got some responsibilities, some values addition, some something which is making us proud. That is more important to understand. FACP is a fellowship of American College of Physicians. It is a upgraded membership. It is a kind of the membership which is you can say advanced membership, or in other words you can say that this is the elite club of the American College of Physicians, in which the people, those who are doing some special in their field, in their job, in their area of medical practice or teaching, whatever they are doing, or research, they are acknowledged with this honorific suffix that is called as FACP. And every physician who gets this suffix, it is a matter of honor for him. It is a matter of proud for him. And but as I already said, proud honor never comes without responsibility. And this is a big responsibility also to a person who is being awarded the FACP, that he should continue doing his best possible effort to make the life easier of our patients, of our countrymen, as well as our colleague physicians in whatever field we are working there.
Very well said, sir. Because the ACP fellowship is again, it comes with a lot of responsibility. And when you got an FACP, then I think the expectation definitely increases as a fellow, and we need to act and behave and in our activities more responsibly, and we need to work towards the ACP chapter also. So, sir, the first question that comes to the mind of a lot of people, that who can become a fellow of American College of Physicians?
Yeah. Before I answer this question, I must clear that every fellow has to pay his membership and all dues as any other member is being done. So sometimes this thought never should come in our mind that if we shall be upgraded as a fellow, then probably we shall not be requiring to pay our dues, and those will not be required then. So this thing should never be remain in our mind. Now your question, who can be a fellow of ACP? All peoples, those who are working in the field of medicine as a medical practitioner, as a researcher, as a teacher in the medicine, in any branch of the internal medicine, or any branch of the internal medicine, or we can say some combined internal medicine specialty, including the neurology, means something related to the medicine they are working, and they must have got their postgraduate certification in the internal medicine or neurology. Then they are eligible to get the fellow of ACP. Now question arises, fellow of ACP can be achieved, FACP can be achieved through two ways. One is that in which it is being awarded as an invited fellowship. Invited fellowship is usually being awarded to those people who are working extraordinarily in their field, and they are being recommended for an invited fellowship directly, even if they are not the member of ACP. So this is a very rare kind of a phenomena, but the people, those who have got very good credentials, they are being awarded with this kind of the category. Another, which is a routine kind of the fellowship upgradation, that is through membership. First, a person should become a member. First, a physician should become a member of American College of Physicians. Membership of American College of Physicians is also coming with lot of benefits. Benefits may be continuous opportunity of getting updated in the medical field, like getting the access of the annals of the medicine, getting the access of the dynamite, getting the access of MKSAP, through which they can evaluate themselves about their medical knowledge. So these are the opportunities which they keep on getting And apart from that, they get the CME credits, they get the networking facilities with the peoples, those who are working in different areas of the world and different other countries of the world, and they remain connected through the American College of Physicians. So these are the benefits of being member, and all those member benefits keep continue when a person becomes fellow, and fellow benefits gets added to that. So after 3 years of the membership, unbroken membership, there should not be any gap in the membership, or there may not be any dues defaulter, then a person becomes a fit candidate for the upgradation of to FACP.
Uh, Sir, many a times now two things are clear, sir, that one of the route to become FACP is that sometimes it can be invited fellowship, but this is very, very exceptional. So I think the message should be very clear. If somebody is having very exceptional academic background or the clinical background and has demonstrated that professional efficiency over a long period of time, then sometimes they may be invited by the governor for the direct fellowship. But this happens very rarely, as said by Dr. Anush Maheshwari sir. But the most common route is that it is advancement through the membership. So one criteria which sir has highlighted is that you need to keep your membership active. So every year, it is the 1st of the June, the membership year starts. So before that, we are expected to pay our annual dues, which are, I think, much lesser than the US dues because of the category in which we are placed as a socio-economic status. Second thing is that we should be, so many of the doctors who are in their first year of the membership or the second year of the membership, they want to know that
Your voice is gone. Amit, we cannot listen you. Amit, Amit, can you listen me? Your voice is not coming. Anyway, in the meantime, I can continue talking about the fellowship, although I couldn't listen the question what Amit was asking to me. The more important thing, we should not always that keep on upgrading whether we get the fellowship, even if we have not received the fellowship, regarding our publications, regarding our continued medical education, and sometimes other educational activities and teaching activities. And uh, Riaz Mohsin, can you people listen me?
Yes, sir, we can listen you,
Okay,
sir.
okay. I think Amit has been disconnected somehow. So let the Amit join. Till then, I am continuing with some of the more advantages of this FACP suffix and honorific suffix. So this is a suffix which is being awarded once a person applies, and for application of this fellowship, a person should get the recommendations of the two fellows or two masters, and finally that recommendation is approved by the governor of the country or chapter, what you can say, governor of the chapter, and then this fellowship is being approved by the uh, board of regents in American College of Physicians, and finally that is the person who has applied is getting the communication that he has been awarded the fellowship. So sometimes this question is arising in mind of many of us, that what are the basic requirements when we can get the advancement to the fellowship. So basic requirements, or if you can make a checklist for your fellowship, in uninterrupted membership of 3 years of the ACP, you should be board certified or your university certified for your postgraduate degree in medicine or some other specialty of the medicine. If you are in clinical practice, your medical license should remain active and updated. There if you are having any 2 years of the experience in any academic position, this adds value to your ACP credentials. Is your clinical activity is focused on internal medicine, one of the subspecialties on neurology, then it makes you more worthy candidate for the FACP. Have you been continuing your professional development and medical education? And you should always be available or volunteer for the participation in some community services and community activity. So you must be able to find your area of professional accomplishment, like uh, your professional accomplishment may be in the teaching, maybe in the community service, maybe in the CMEs, maybe in the research, or you should be able to keep on doing it continuously. Publications are always a very important method of keeping you rising and keeping you upgrading, and that is a very important thing whenever you are doing some research work or doing some activity. We always prefer that all members of the ACP, especially in the India chapter, should start using the EMR, because that is the way through which they can keep their records well, and this will help them in producing the data. This will help in producing the small studies. And
Yes,
apart
sir.
from that, the leadership qualities should also be tried to develop in ourselves. So this fellowship never comes only with the suffix of FACP. This, as I already said, this comes with a lot of responsibility, and we should always try to understand or fulfill those responsibilities. Amit, now you are back?
Yes, sir. Am I audible and visible to you, sir?
Yes, yes, yes.
Yes. So, sir, a very common question that most of the members they ask, because many of the ACP members, they are busy clinicians. They are not able to do publish papers or do some research work. So they always say. Just today, I had a chat with a couple of people, and they simply said, "Oh, we won't be able to publish anything. So why should we become ACP member since we won't be able to advance to the fellowship?" So is it an essential criteria to have some publications, sir? Or if somebody, yes. So I think please highlight that more, sir.
It is not at all an essential criteria that you should have the publication. Publications can only be of those people who are in the research or who are in the teaching. Those who are in the private practice, those who are in the clinical practice, they may not be having enough time to write paper. They may not be having the structured method of collecting the data, because when you are doing the practice, then you may not be having enough time to think that which patient is to be kept in which category and how to structure your research and all that. And every research, any prospective research is requiring the ethical clearance. So whenever you are doing any such thing, you need to plan your protocol before, you need to make your CRF, get the ethical approval, and then you can start. So this is not a thing that you just thought and it has happened. But one thing is very important, and it must be understood by all of us. By using EMR, we can get a lot of retrospective things uh, from our own patient records, and that helps in getting the real world evidences. And those real world evidences are very much helpful in updation of our colleagues' knowledge, our own knowledge, and what I understand, what I have done in my clinic, that even I have developed a method of evaluation of my own clinic also. For example, after 6 months or 3 months, I just see that how many patients entered in my clinic with this much of the HbA1c and how many patients got controlled. So this gives an idea about my own efficiency, how I am being able to deliver, what quality of the patient service I am being able to deliver to my patient. And this also adds value to your upgradation as a good clinician in the society. So it is not only the publication. Apart from, as you said, that as far as the FACP is concerned, apart from publication or instead of publication, if you are doing some social survey, if you are doing some community surveys, if you are doing some community study, if you are involved in teaching and getting praised by your peers or getting uh, some good credentials or some good words by your peers or your friends or your seniors, then these things can become uh, instrumental for upgradation to FACP from a simply member to the ACP. So it is not at all required. But here one thing I would like to add, that if a person in India is requiring a lot of research, if a person is having his inclination towards the research to collection the data, from ACP we are doing lot of opportunity creation for collective research. We are collaborative research and collective research. And we are not only investing fund, but also providing the platform, also providing uh, the basic support to get the people accomplish some data collection on some very important and pertinent topics which are required for our own country's health.
Right, sir. Sir, it is you have very rightly highlighted that it is, if you want to get engaged in research, then the ACP brings you a lot of opportunities. And if you are not able to do the research, then it is not the only criteria to the advancement to the fellowship. Sir, many of the times now the ACP is doing a lot of activities, the online activities, the conferences, so how does that help if somebody attends these conferences, if somebody attends these webinars, and then they write this in their CV? So does that makes any difference to a CV in which all these activities are not there?
As far as as you very rightly said, that FRCP upgradation may be requiring engagement in the ACP activities. And that is the most important condition of upgradation. The person who wants to be upgraded at FACP, he should become the member. He should deliver something to the ACP. He should work for the ACP or on the platform of the ACP, work for the patients and work for the people. And then he should expect that he should be upgraded to the next level. And after FACP, there is another level, that is the Masters of ACP. So these levels can be reached only when you are delivering something. And how can you deliver? You can participate in the community activities of the ACP, like we have started the IRIS project, and this has been conceptualized by the Amit Gupta himself, and he has worked a lot on for the IRIS project. Apart from that, last year we also did some of the projects on the public service and some of the research projects we are supporting. Some of the things we are doing in form of the CME for the women's health, for the nutrition, for the adolescent nutrition. We started doing some workshops, and we are also trying to prepare uh, some documents or some draft through which we can improve the adolescent nutrition in our country. So there are multiple things through which a person can be engaged in the various activities. And those engagement will not only help him to upgrade himself in the FACP or MACP, but he will be directly or indirectly helping or serving, or you can say serving his own country, his own motherland also. So that's satisfaction will also comes to your mind that, or it comes to your heart, that you are not only doing the practice, or you are not only earning money, you are also serving the people. So earning with the serving is the best thing what a person can get after becoming clinician or doctor.
Yes, sir. Sir, one more thing I would like to ask. Many of the time, some of the members, they are not able to write a proper CV. So what is your tips for them that how to write a good CV whenever they are applying for the FSCPC?
Yes, it's a very important thing to understand how to write a good CV and how to make it very impressive. And I will suggest you to keep one program on this topic only. Some future ECP case file, you can keep half an hour time for the how to write good CV, and in which we can talk with a few of the experts. I may be there or somebody else also may be there. So whenever you are writing a CV, what I understand, you should first give your crisp introduction in the beginning. And after the introduction, you should write your present position, whatever the present positions you are holding. And then you should start giving your credentials in the form of the awards, then in the fellowships, whatever you have received, or some accolades you have received somewhere from some organizations, or oration you got opportunity to speak in somewhere or some organization. Then you should give your list of the publication and papers, and finally the community service is to be mentioned, and then your CV would be complete. And that CV, after making it properly, should be signed. It should be updated after certain time. After every 2-3 months, you should not forget to update your CV, because your CV is your value, is deciding your value. Whatever the CV you will be putting up, ultimately that will make you, and actually that is your reflection. Because you cannot be available or you cannot be present everywhere. Your CV represents you, and it gives you, and it should reflect your personality. It should reflects your credential. It should reflect uh, your means how much intelligent you are. It should reflect your intelligence and everything. A person who is seeing the CV, he should understand that to whom I am going to talk after looking over this CV.
I think, sir, one of the best thing is that one can do is, if suppose somebody is planning to apply for the FSCP after 6 months or a year. So this is the time that you start building up your CV and try to identify what are the areas where would like to add something, or you would like to get engaged so that you get something to write with that. So I think starting to write a CV is not an emergency thing. So don't keep it to the last minute. So it is the most important document which you will be sending or uploading to the ACP. So I think it is important to plan a good CV and write it in time. Sir, I think there may be many questions, but one of the most important question that comes to my mind is that sometimes the member may want to become and may want to apply for the FSCP, but they may not be knowing any of the fellows, right? So can they approach to the office, the ACP India chapter, so that ACP itself can guide them regarding
Yes.
how they can get the sponsorship letter or the recommendation letter?
Yes. So if they are members, so they are always connected with ACP India Chapter office. They are always connected with me, because you know that I am continuously connected with all members. I am writing to all members. I am writing mails to everyone. At least in 1 month, 5-6 mails I definitely send to all members. So they can write back to me. And if they will be writing back to me that if they are finding any difficulty, then I will solve the problem, whatever they are having. And in fact, I have done this in the past also. When I have been taken over as a charge of governor, a lady whom I never knew, she written me that I want to get the fellowship of ACP. I am member of American College of Physicians for last 4-5 years. Can you help me? I don't know anyone who can forward my application. So I just gone through his CV and arranged that it should be forwarded properly. And it next week or next another week, next 2 weeks, she got the confirmation of the FACP. So these help we are always ready to give, and we do this. And you know that many times I have also forwarded few people to you also to recommend. So if anybody is willing to become FACP and he deserves to become, he is fulfilling all the credentials, he is welcome to write me or my office, and we shall surely be connecting with the appropriate eligible people who can recommend him, or if they may be in their area, we can also help the persons finding the appropriate people from their area. For example, if someone is in Hyderabad and he writes to me that I want to apply, then I can suggest you name of Riyaz, suggest the name of the this Aslam, that they can recommend those people that for the FACP. So these things, if somebody is from Delhi, then I can recommend your name. If somebody is from Jaipur, then I can ask Dr. Daria to help him out. So we are having lot of connection, and many times I understand that biggest benefit of being a member of ACP is good networking. So you are not alone in this world. And once a person says that I don't know anyone who can recommend my CV or who can recommend me for the FACP, sometimes I surprise how did it come? Because how could it be ever possible that a person is not being connected? But it happens that people remain shy. People are not willing to tell anyone that you recommend me. Sometimes they may also be fearing that next person may not refuse and may not say that, may not respond properly. So these are the inhibitions which remains in the mind of the people. But we are here to help them out of these inhibitions. And if they will write to us, if anybody will write to us, we will help them to get through out of the problem.
I think, sir, this is the time where the ACP India chapter is one of the most helpful chapter, and it is always ready for the membership. And Dr. Anuj sir is always approachable, so you can always approach him if you have any difficulty. So just remember a few things: that keep your membership active, keep your annual dues always paid, so that there is no problem with that. Start building your CV, and keep yourself engaged in some of the activities. It is not necessary that you do all the activities, but try to attend the annual conference of the ACP India chapter. Try to attend some of the seminar and the webinars. Try to be a part of some social activities which are being conducted by the ACP India chapter. Research opportunities are also there, and the mail goes to all the ACP membership. So please, India channel in your mailbox. And if it is going into the spam box, then please mark it to the primary mailbox, so that you don't miss out on the important information, because all the information are being sent by the ACP Headquarters India chapter on your mail. So with this, sir, I would like to ask your final comment on the advancement to the fellowship, because once I heard you that you told us that it is your dream that you want each and every member to be an FACP.
Yes, I really, today also I want that every Indian physician is having the capability of becoming the FACP. Because the amount of work what we do is unmatchable to any country, any physician of any country. So this much of the work is being done by our people. They should get this this suffix or this honorific suffix in return of that. So I wish that every physician of India become the FACP, but before that they should join the ACP. They should start working in the ACP. They should start working in their respective field. They should remain. They should enjoy the being connected with others. So I invite all of you to join our ACP community, as well as join our ACP India annual conference at Vizag. Get yourself registered for that. Come there, enjoy that conference, being a part of the networking sessions, and then you may not be having any dearth of the proposer and seconders for the FACP, and you will automatically, and it will give you a very good mental uplift also once you will be in so many colleagues and will be sharing your experiences, will be sharing your own practice ideas and research ideas and results of the your clinical practice, especially in the bad COVID times, where everybody has got his some own experiences. So I always prefer that people should be there, and I always try that annual conference should not remain simply a compendium of the sponsored talk. I always prefer that it should be a conference in which the people may get what they really want. People may get something very close to their heart, which can help in their practice. This year, we kept our theme also back to basics. So in back to basics, you will find so many things which will take you to the back uh, to the basics where we have started doing so many things, and good things were there which we have forgotten. Today I was taking examination with some student. So after getting the complaints, everybody jumps to the investigation. Clinical examination art is lost somewhere. So we should get it back, how to get the diagnosis with the clinical examination. So these are the things what I really wish that people should come back on that and just, include in their practice.
Thank you, sir. We had a wonderful discussion, and our membership must have benefited from your insights into the advancement to the fellowship.
Dariya, Dr.
Ah,
Dariya, yes,
sir,
please.
Dr. Daria.
yeah. Sir, can we have a list of already the member who have got the FACP? So
Yes,
that,
yes.
so
We are having a
I
list
think
every 3 months or 4 months, whenever the
sir,
fellowships are
uh,
declared, the
yeah,
list is
sir,
there.
at least provide the whole list to the ECP members, ECP council members, so they can contact the people who are not the FACP. So
Yes.
we can help the state-wise everybody to get the FACP and to get the nominated for the FACP. So we can help out them that these people who are their CV is very good, but they have not taken the ACP still. So if we'll have that list state-wise, then we can help those who have not taken that FACP.
There is one clause in the ACP constitution. It is not ACP India, but ACP constitution, which says that we should not disclose the contact details of the members to any third party. So, for that reason, I can definitely provide the list of the people, but I cannot provide the list of the people with their phone number and their email ID until
Only
unless
name figure.
I don't get the consent from them. So what I usually do, if anybody contacts me that I am not getting any person who can forward me or who can propose me for the FACP, I just tell them these are the people who you know them. If he says that no, I don't know, then I directly call to those people who are the and ask them to help that gentleman, and I connect both of them one to one, and usually they get. So I will definitely provide the list without phone numbers and email ID.
Thank you,
Yes, sir.
sir. With your permission, now we would like to move to the second part of the program, sir. And
Yes,
today
yes.
we have Dr. Satish K. Gupta, Dr. S. K. Gupta, who is a very senior physician with us as a moderator. Welcome, sir. I will request Prachi to share the introductory slide of Dr. S. K. Gupta. Dr. S.K. Gupta is based in Delhi NCR, sir, and he is a very senior physician. He is author of the book Journey of the COVID in India, a doctor's perspective, and the book got laurels and appraisal from the United Nations. He has written many chapters on the COVID in several books. He is teaching faculty in the Department of Medicine at Chaudhry Charan Singh University, India. He is also been honorary consultant physician at the Max Hospital, New Delhi, and he is an alumni of prestigious Maulana Azad Medical College, New Delhi. And in addition, he has also been conferred upon the fellowship of the Indian College of Physicians. Also, he has received many other fellowships, and he has more than 40 national and international scientific publications. And he was also nominated as Delhi Healthcare Ambassador for Delhi Medical Association and Chikitsa Ratna Award by the IMA. So, welcome, sir. Now the stage is yours. Dr. S.K. Gupta, are you there, sir?
Thank you, Dr. Anuj Maheshwari, and thank you, Amit, for inviting me to this August forum. It has been a wonderful time till now, listening to Dr. Maheshwari and knowing more about ACP. And now I think that we should straight away, without losing much time, go to the topic of the day, that will be interesting case of ascites. And Dr. Mohsin Adam has been told is going to present the case. Can I invite Dr. Mohsin to start this presentation?
Yes, sir.
Rachi, can you display the intro slides of Dr. Mohsin?
Dr. Alam is MBBS MD in internal medicine and MMSc endocrinology from the University of Nicaragua. He is a consultant physician and a clinical endocrinologist at Asian Hospital, Gastroenterology, Hyderabad. And his basic achievements, his main achievement is the Strategic Center for Obesity Professional Education, is scope certified for the obesity management, and is an alumni of Academy of Young Leaders, CUHK, University of Melbourne. More than 25 publications and lectures at local CME and international conferences, more than 20 publications in peer-reviewed journals. So, Dr. Alam, the stage is yours now. You're welcome to start with your presentation on the topic ascites, an interesting case. Ascites has been there for a very long time, and the things have been evolving. We're going to learn more and more about ascites today. Let's see what Dr. Alam has.
Thank you, sir. I'll share the screen. So today I'll be presenting a case of ascites, an unusual presentation of a rare disease. So a 34-year-old male with a sedentary lifestyle presented with the complaints of pain, abdomen, and fullness for a week, 1 week. The pain abdomen was diffuse, dull aching, non-radiating, and it was present throughout with no relation to meals or defecation. And initially, the abdominal fullness and nausea was there post-pandally, but slowly he noticed that it was abdominal distension, which was gradually increasing over 1 week. There was no history of fever, weight loss, difficulty in swallowing, vomiting, swelling of lower limbs, facial puffiness, breathlessness, or cough. And he had no other comorbidities. He had similar complaints 3 years ago and 1 year ago. He was evaluated outside and ultrasound showed mild ascites, was managed conservatively, and his symptoms subsided in 2 to 3 weeks. No history of any allergies, no history of any coughs in the past or any surgeries in the past. Family history was not significant, and personal history is non-vegetarian, no addictions, sleep normal, appetite normal, and bowel and bladder habits were regular. There is no drug history, means not allergic to any drugs. So on examination, he was well built and nourished, and BMI of 31.5 kg per meter square. Vitals were stable, and general physical examination was grossly normal. Because the patient had ascites, we started with GI system examination. Oral cavity was normal. Abdomen was diffusely distended with fullness of flanks. Hernial orifice was normal, and all quadrants moving equally with respiration. Umbilicus was inverted, no scars, sinuses, or dilated veins. On palpation, abdomen was soft, non-tender, no hepatosplenomegaly, and no palpable mass. On percussion, shifting dullness was present, and on auscultation, normal bowel sounds were heard. There was no brie and no venous hum. Rectal examination was normal, and other systemic examinations were almost normal. So with this history and examinations with ascites, we thought of most common cause being chronic liver disease, decompensated, the other being abdominal coughs, or acute pancreatitis because the patient had pain, or maybe ruptured hydatitis, or vasculitis, Crohn's disease, eosinophilic ascites, and some parasitic infections, and malignancy might be the last option. So we started investigating. On investigation, CBP showed TLC of 21,900 with eosinophils 52%. And ESR was 7. Peripheral smear showed leukocytosis with eosinophilia. Serum IgE levels were normal. LFTs, kidney function tests were normal. Thyroid function tests were normal. And serum calcium normal. And stool for ova and cyst was negative. So lipid profile again normal. Viral markers were negative. Ascitic fluid analysis showed yellow colored fluid. ADA levels were 5. Total count of 6,950 cells with 95% eosinophils. And protein 4.9, albumin 2.7 with no malignant cells, a SAG of 1.5. So ultrasound abdomen showed fatty liver with a minimal thickening of omentum, moderate ascites, and clumping of loops in pelvis. Thickening of walls of distal body of stomach. CT was done and it showed diffuse thickening of, here you can see, diffuse thickening of proximal small bowel with mild ascites. Then we performed an upper GI endoscopy, which showed concentric rings in the esophagus and gastritis, small erosions in the antrum of the stomach and fundus, and also erosions in the duodenum. Ileocolonoscopy was performed, which was normal ileocecal region and colon was normal. So biopsy from the esophagus showed, because it was a superficial biopsy taken, it showed just benign squamous mucosa with no evidence of granuloma, dysplasia, malignancy, or any intraepithelial eosinophils. Again, duodenal biopsy, it showed, you can see there was a shortening and widening of the duodenal villi, and there was mild villus atrophy with no surface parasites, granulomas, or no intraepithelial eosinophils. Bone marrow examination was done in view of very high and persistent eosinophil counts. So marrow showed increase in the marrow examination and trephine biopsy both showed increase in eosinophils and eosinophil precursors, no abnormal cells. We thought of ruling out some eosinophilic malignancies or CML. We performed PDGFR alpha and beta, both were negative. So final diagnosis of eosinophilic ascites with eosinophilic gastroenteritis with subserosal involvement was made, and patient was started on prednisolone 40 mg per day. The patient's symptoms subsided after steroid treatment for 2 weeks, and his steroid dose was successfully tapered within 3 months. And the patient is almost followed for last 1 year without any recurrence of the symptoms. So can we stop here and have a discussion, or shall we go for a discussion part?
I think eosinophilic gastroenteritis is not a very common disorder here in India. So what are the other things that you're going to look up to pinpoint towards the diagnosis of eosinophilic gastroenteritis?
So usually we need to do full thickness biopsy or diagnostic laparoscopy to prove the biopsy diagnosis, because it's mostly involving the serosal or subserosal layers, which is very difficult to get it from the normal biopsy. We also planned for doing enteroscopy, but due to financial constraints, it was avoided. And because we already had evidence of eosinophilic ascites, and so we started him on treatment, and he responded very well to the treatment.
Any evidence of something like Loeffler's or something like lymphatic pilosis along with it?
No, nothing.
So do you feel that this was not associated with the tropical eosinophilia?
No, because Ig levels were normal, and even in the biopsy there were no parasites seen.
That's really wonderful. That the Ig levels were normal, and there were no parasites. And had you done a stool examination?
Which examination?
Stool examination.
Yes, stool examination was normal for ova and cyst.
That's fine. Yeah. I think now we should move forward. Dr. Amit, you want to say something?
Riaz, Dr. Aslam, I just wanted to know that you have shown one of the picture of the upper GI endoscopy, and it shows the concentric rings. So
Yes.
I think I've seen some of the images in internal. This is where you have seen the rings are there. So I
Yeah,
think
this,
this is just esophagitis also.
yeah, but biopsy, no, not esophagitis, but sometimes it is not typical of eosinophilic esophagitis. Sometimes in other conditions also it might be present, but biopsy did not show any abnormal cells. This was a biopsy from the
But can
esophagus.
you be a little bit louder because your voice is not coming properly to us? It is muffling.
Okay, am I clear now?
Yeah.
So this we have done biopsy also from esophageal, but we did not find any abnormal cells. Only it was a benign squamous epithelium, and it is, yes, characteristic of eosinophilic esophagitis, but sometimes it can be present even in other conditions like where there is no eosinophilic esophagitis. It can be non-specific also sometimes.
Dr. Aslam, I think the presentation was very deceptive. So it was not very straightforward, and many of the things you looked for were normal. So I think you must have evaluated this patient extensively.
Patient was initially treated with only PPIs for 2 years.
Yes.
And when he developed ascites, that was the time we found he had eosinophilic ascites, and he started with on steroids, and he responded very well to steroids.
Dr. Aslam, how do you how do you explain that the recurrent phenomena? You said that the patient was having similar illness 3 years back also. The last 3 years, but every
Yes,
year.
but yes, he had two symptomatic improvement with PPIs, and it was only mild ascites. Maybe patient was treated with some Montelukast or some other medications outside.
There is no treatment history along with it.
No treatment. He said he was given some medications, but he has no. One was some PPI medicines, and other medicines also he was.
Were any
given,
investigations done in the
definitely not
past?
steroid.
Any investigations done in the past?
No, only ultrasound and routine blood tests were done, and eosinophils that time also was very high, around 25 to 30%.
And he has been living in what area like?
He's in a proper. He's from proper Hyderabad. He works in an IT company.
Where does he live?
Hyderabad city.
Hyderabad.
Yeah.
Do you have the incidence of higher eosinophil counts or some other parasitic infections in the Hyderabad?
No, not many. Patients present with allergic rhinitis or allergic bronchitis with increased eosinophil count may be up to 10 to 11%, but not very high, and not presenting with GI manifestations.
Right. So I think, Mohsen, would you like to proceed with the discussion of this case?
Yes.
Yes.
So eosinophilic gastroenteritis is an uncommon disease characterized by eosinophilic infiltration in the GI tract. It involves one or more layers of the GI wall and other abdominal organs. It is described in all races and continents with slight predominance among Caucasians. It is more frequent in males, 3 to 4 times more common than females. The mean age at the time of diagnosis ranges between 30 to 50 years in adults and 5 to 10 years in children. So, etiopathogenesis, several hypotheses have been proposed. One is hygiene hypothesis, that is fewer childhood infections with microbes resulting in decreased protection against allergy development, and microbial dysbiosis as a result of modern affluent lifestyle. Environmental factors like pesticides contaminating crops, livestock treated with hormones and antibiotics, food additives and processing changes, and pollutants in the air and water. And increased use of PPIs that prevent peptic digestion of food allergens, increase gastric permeability, and alter the microbiome to favor food allergy development. And specific IG4, that is antibodies to cow milk proteins, are common. So the deterioration of the epithelial barrier as a result of genetic predisposition, reflux, and food intake. So invasive allergens and microbial antigens activate the innate and acquired immune systems, as a result of which The eosinophils degranulate, release toxic proteins, and generate alterations in extracellular DNA, which serve as a defense system but also cause tissue damage. So, while releasing different cytokines, eosinophils modulate the inflammation and promotes its chronification, finally resulting in fibrosis, which in turn has negative effects on barrier function of the skin. So, clinical presentation depends on which layer and locations are involved. Mucosal involvement leads to protein releasing enteropathy, fecal blood loss, and malabsorption. Involvement of muscle layer often causes obstruction of gastric outlet or small bowel obstruction, and subserosal involvement manifests as eosinophilic ascites. So the most common symptoms are pain abdomen, nausea, vomiting, and diarrhea, depending on the GI tract where it is involved. And mucosal layer involvement is the most common with 58%, and subserosal disease is least with 12% presentation. So patients with subserosal disease could be distinguished from the other two groups by clinical symptoms like bloating and ascites, high eosinophil counts, and their dramatic response to steroid therapy. Diagnostic feature of subserosal disease is marked eosinophilia up to 88% in the ascitic fluid, and our patient had almost all the features. This feature may be confused with cirrhotic ascites or abdominal carcinomatosis. Marked eosinophilia in the ascites is an important clue to get the diagnosis of eosinophilic gastroenteritis. So radiological features, thickening of mucosal folds demonstrated by barium study or CT scan or ultrasound depending on the severity and the layers involved. Other diagnosis to be kept in mind is Meniere's disease in case of the thickening of the stomach, lymphomas, particularly maltoma, Crohn's disease, involvement of the small bowel and large bowel, and granulomatous disease like Cox. And thickening of bowel wall is not specific only for eosinophilic gastroenteritis. So findings, non-specific, it can be present in any other disease in endoscopy. So it may be erythematous lesions, friable nodules, and occasional ulcerative changes might be there in GI scopy. On biopsy and diagnostic criteria for eosinophilic gastroenteritis is presence of GI symptoms and demonstration of eosinophilic infiltrations. These are the red color eosinophils in areas of GI tract on biopsy, and no evidence of parasitic or extraintestinal diseases. So treatment, clinical response of eosinophilic gastroenteritis to steroid treatment is usually dramatic. However, the duration of treatment is unknown. Improvement usually occurs within 2 weeks, regardless of the layer of bowel involved. And some patients may need prolonged therapy, maybe up to several months, to induce resolution of symptoms. And patients with refractory relapsing disease may require long-term low-dose steroids or immunosuppressive therapy. So to summarize, eosinophilic gastroenteritis presenting as ascites is a rare disease, and it should be suspected in the presence of unexplained chronic or relapsing GI symptoms. Ascitic fluid analysis is helpful in the diagnosis of eosinophilic GE with subserosal involvement, and steroid is the mainstay of therapy. Thank you.
That's really wonderful case. And Dr. Alam, it will be interesting to know, how did your patient respond? You gave him steroids and you felt that the ascitic fluid has got absorbed, the symptoms have improved.
Yes, his bloating symptoms and abdominal distension also was reduced, and he felt much better. Symptomatic relief was also there. So we continued him to continue the steroids for him up to 3 months and tapered and stopped it.
Then you tapered and stopped, and the patient did not have any recurrence. How long had you followed up the patient?
Following this patient for last 1.5 years.
And the patient is comfortably well.
Yes, yes.
And any other like sometimes it might be very difficult to rule out the history of parasitic infections, which might be which might be covertly there in the body. Had you given him any
earlier
anti-parasitic
they had
agents?
dewormed him, so 2 to 3 times they have dewormed him also.
But it's really a rare case, and it's really wonderful. And the ADA was pretty low. And any patient of ascites in India, we would first think of tuberculosis And then some like, how did it come to you that it is eosinophilic gastroenteritis? Like, when did you first think that we are dealing with a patient of?
So we work in a gastroenterology institute. So the moment the patient comes with ascites, first thing we do is we do ascitic typing.
And the ascitic type clinched the diagnosis.
Yes.
Any specific belt where this patient comes and you find that the incidence of eosinophilic disease is much more common in that
stays
area?
in Hyderabad, and that too in the IT area. So unlikely to be. He's in proper city.
One thing which I wish to emphasize, but like Dr. Alam has also said, those patients who have history of infections, especially the like covert infections, the undiagnosed infections, suppose UTI a patient had in the childhood, these patients are much more prone to develop allergic manifestation later in the life. They might develop urticaria, they might have much more allergic symptoms, and they might have angioedemas. But I didn't know that they might even have eosinophilic gastroenteritis. It is something very new to me. But I've seen patients who had history of infections in the early childhood, prolonged infections, and they developed urticaria, and they had repeated episodes of angioedemas in their adolescent life. But this is something interesting case. Thank you. I think it is a wonderful case. Doctor, somebody else wants to ask a question. Dr. Yaz, he wants to say something.
Yeah, Mohsin, I think the case was a little bit unusual because we don't think ascites could be the first cause. Whenever we see in our clinical practice, as Sir has said, we always think about tuberculosis. Now, my take is like, did you follow up this patient, and do you think like what was the follow-up? How long you have followed up this patient?
I mean, even the details, history, imaging. Again, I called him yesterday, day before yesterday, and collected all the details from him. So I've been following.
And Aslam, I think you are working in a gastro setup. So in some cases, you have seen this type of a picture. So what do you think, like the recurrence of the symptoms may occur in the patient despite starting steroids? So don't you think like the monoclonal antibodies or the newer drugs, which are like dupilumab, can be used for these patients? So what's your experience? Any take on it?
No, we have not used, but we have patients without ascites who are presented with eosinophilic esophagitis, who are doing very good with local budesonide therapy.
Okay.
Budesonide in inhalation, you mean to say?
Sir, budesonide.
How do you give budesonide to these patients?
So now budes tablets are available.
Your patient just swallows it.
Yes.
And don't you think like there will be some precipitation of GI manifestations if you are giving oral form of steroids?
No, it's a very local steroid, and it's not that potent, so they don't have any symptoms.
Fine.
I think again an excellent case, Dr. Mohsin. Two key takeaways which I got from this case is that excessive use of PPI should be avoided.
Yes.
Because people keep on taking PPIs for years together without understanding that they can be really dangerous. Since you are working in a gastro institute, so a real a message from you on the use of PPI, I think it is very, very important. And also the use of antibiotics and the other things in the livestock. And so people are consuming a lot of dairy products, and the livestock is treated with antibiotics and other things, leading to a lot of food allergy and all. So I think, Mohsin, we would like to listen to you on these two aspects.
So we usually tell people who have been using PPIs to, we shift usually the patient have been using PPIs for many years. We ask them to perform an endoscopy. If everything is normal, we tell them, okay, yes, your gut is very sensitive. You become sensitive to this because of the using medicines. Better stop PPIs, and we put them on antacid syrups and gels, and maybe for 3 to 4 months, and then ask them to take PPIs only on demand.
Dr. Amit, my take is that patients who have occasional gastritis or some heartburn, occasionally, and they go on to the PPIs, and once they stop PPI, they have a rebound acid secretion, and they pick up the PPI again, and they sometimes feel that they just can't manage without it. And I would be very particular in telling these patients that PPIs are there only for a week or so. Then I should gradually shift them into the prokinetic agents like domperidone or similar agents. And then, as Dr. Alam has said, that we shift them to as well as antacids. And in case they require it once in a while, once in a day, like once in a week or twice in a week, they may switch on to PPIs. But PPI is not an alternative to to eat too much, not to do exercise, wear tight clothes, have a late night sleeping schedule. I think, I think that needs to be corrected.
Yeah, but some people, despite having good lifestyle modification, they have very sensitive gut, we can say, and even with slight amount of spice or what you can say, any citrus foods, they develop so much gastric irritation, okay, they won't be able to tolerate it.
And for those people, I believe the prokinetic agents are going to be much more helpful.
Yes.
I can also see, sir, Dr. Saurabh Srivastav, Dr. Gauri Shankar, Dr. Preeti, Dr. Manohar, and many of the other senior physicians from the ACP India chapter, they have also joined. So if they would like to ask anything or they would like to make any comment on the case, or if they would like to highlight anything, they are most welcome.
Hello, sir. Dr. Gauri Shankar from Coimbatore, sir.
We can't see you, Dr. Gauri Shankar.
Sir, I'm in driving, sir.
Okay.
I'm listening to you. It's a fantastic case, sir. Really admired by the way sir has presented. I think many of my students are watching this presentation. What I want to convey to them is the common presentation is what we are regularly seeing is ascites. If we see moderate ascites, first thing comes to our mind is decompensated liver disease and followed by tuberculosis. Apart from that, there are so many diseases are there which are also causing moderate ascites. One among is eosinophilic gastroenteritis. It's an uncommon disease, but we should know that as students, they should know that. Thank you for highlighting this rare case, sir, because this is the first time I'm hearing this case, and we enjoyed this session. And I think this ACP has doing a wonderful job, sir, because it's connecting students, practitioners, physicians, and all the specialties. I think wonderful job done by our governor, Dr. Anuj Maheshwari, sir, and Dr. Amit ji. It's really awesome. Thank you for highlighting this case, and thanks to speakers.
Thank you, Dr. Gauri. I just like to say one thing. Many of the times, somebody may think that why we keep on bringing rare cases because we don't see them often. So, idea of highlighting rare cases is that it makes us think. It makes us think more, and it makes us think and investigate in the right direction. So, unless and until we look for the rare things, then it can be very, very misleading at some of the time. So we don't. So every time we think that ascites is going to be CLD or tuberculosis only. So I think this is what we don't want exactly to happen, and that is why we keep stimulating our brains that we want to know even the remotest possibility. So this is
right, sir. Rightly said, sir. Right, sir. Thank you, sir. Thank you for the opportunity, sir.
Dr. Gauri Shankar had made a wonderful comment, and I really appreciate for him to be so candid that he has seen it for the first time. And myself also, it is really the first case that we have gone through. Dr. Alam, I would like to stimulate some discussion. Did you ever think of giving diuretics to this patient? And which are the patients of ascites who are going to respond to diuretics? Because the moment ascites comes,
we don't start off diuretics until unless we prove it is because of some cardiac cause or liver-related cause. We don't give diuretics in our patients. Even abdominal cause also we don't give diuretics.
How will you decide this patient is going to respond to diuretics? I mean, even in the CLD, or not all patients will respond to diuretics.
All patients.
Do you do some investigations?
We usually do renal resistive index to look for HRS, early HRS, because sometimes if we give diuretics in this patient, that patients might worsen. So, and if it is tense ascites, what we do is we give albumin and do large volume paracentesis and discharge them on low dose steroids. We follow up them every 10 days. If they are not responding, then we start them on midodrine along with low dose of steroids. Diuretics.
The key takeaway is that people don't have to start them on a very heavy dose of diuretics. If at all the diuretics are required, then they should be given to the patients in low dose, and plasma renin activity is one test which might help you in case the plasma renin activity is more than 4, then these patients are likely to respond to diuretics. In case the plasma renin activity is less, then these patients may not at all respond to diuretic, and these patients will, what they will need is the rest and the diet.
And also high protein diet and low salt diet definitely helps in cirrhotic patients.
And Dr. Sam, just tell me, how do you differentiate whether this patient is having a primarily a kidney disease and or it is basically hepatic renal syndrome?
Kidney disease, usually they present with facial puffiness also. To start with facial puffiness, and then later on pidal edema, and then later on they'll have ascites.
But when a patient comes to you with both the things, you have the ascites and you do the renal parameters, they are found to be decreased. It is sometimes very difficult to really make out which came first.
If it is an AKI or HRS, it's very difficult to make.
Exactly. And it might be very difficult to give them steroid, give them diuretics also, because you have to be very careful.
Yes.
These patients are really a cash in management.
So I think, sir, we had a wonderful discussion. So one last and final comment from our moderator, Dr. Satish K. Gupta, who has moderated this session very well, and he accepted our invitation. We are very thankful to you, sir. So what is your final comment on the case, sir, and what is your message to the larger audience?
Firstly, I'm thankful to the ACP for inviting me to moderate this session, and it was I'm also thankful to Amit and Dr. Maheshwari to accommodate me to have joined slightly off time because of certain preoccupations. Anyway, thank you very much, all of you, and it was a really wonderful case. I never expected such a good case, and the key message is that kindly avoid PPIs. If at all they are required, they are to be taken off and on. They are not basically a daily digestive pill. And secondly, in the diuretics, in case the ascites is there, do not jump onto the diuretics. Kindly try to establish the diagnosis. And once you have made the diagnosis, then you do the therapy accordingly. And in case you have to take the opinion of the specialist, do not hesitate to go for that. But definitely the eosinophilic gastroenteritis does not remain the diagnosis of first choice. The first choice still remains the chronic liver disease or the tuberculosis followed by the malignancy. And of course, eosinophilic gastroenteritis will always come to your mind whenever you are seeing difficult cases and whenever a diagnosis is not being made. I think that's all for today.
Thank you, Dr. Gupta, sir, and thank you, Dr. Aslam, for presenting such a wonderful case. I think all of us have learned something new today, and all of us have become more wiser. And it will be helping us in our clinical problem solving whenever we see a case of ascites. And thank you, Dr. Riaz. Thank you, Dr. Saurabh. Thank you, Dr. Preeti, Dr. Abhishek, Dr. Manohar, Dr. Gauri Shankar, and all the other ACP members who are watching us through the direct telecast. So once again, those who joined late, let me just inform you that just yesterday it has been announced that ACP India chapter has the performance of the ACP India chapter is now ranked as a gold category. So we are one of the few chapters all across the world out of the 180 plus chapters whose performance has been rated as a gold performance. And Dr. Anuj Maheshwari sir is leading the chapter in a big way. So I will request you to participate in the ACP India chapter activities as much as you can. And we will see you again next week for the another episode of the ACP India chapter case files. So last comment from Dr. Saurabh. I can see Dr. Saurabh also, who is professor of medicine at James.
I am here in one of the presentation. It was a wonderful presentation by Dr. Aslam, and all the things have been discussed. So there was nothing much to add. Dr. Gautam has and Dr. S.K. Gupta has beautifully moderated the session, and he has given all the key points. So nothing much remains to be added. It was a wonderful presentation.
Thank you. So thank you, everyone. Bye-bye, and see you next month in another episode of ACP India Case Files. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir. Thank you so much.